Thank you for showing up. I realize it's the end of a very long day, and I think everybody's probably ready for a beer by now. So I wanted to kind of flip the format a little bit. Is this really loud? It sounds really loud to me. Or is it good? Okay. I wanted to just take a temperature of the room real quick. If anybody has now like some burning questions or like why they showed up for this talk, let's get them out. And then that way I can try and talk about them a little bit more. Because I feel like it's the end of a long day. I want to make sure that it's worth it for you guys. So does anybody have anything that they're like, I came to this talk because I really want to learn about? Yeah? Go on, shout it out.
Thank you. I came to this talk because I'm really curious about like automation in healthcare and how far you can go with and how much sense it makes to replace human doctors with robot doctors, and in a totally like non-emotional way for me personally, but I know it's like a very emotional issue, so that's
Great.
what I'm curious about.
All right, I'll talk about that. Anybody else? Yeah?
I'll get you the microphone. Hang on.
Sorry.
I'll be running around.
I'm very interested to know your experience and knowledge in area of data privacy and how that may reflect maybe implementing some innovations in different regions, especially Europe, North America. It's very different conditions in healthcare.
Yeah, okay.
Can I just piggyback on, in 10 years, best case and worst case scenario
Around data privacy?
around AI in
AI,
healthcare?
okay. Best case, worst case, I got you. Okay.
Anyone else? Yes, up.
Hi.
Hi.
I am interested in learning more about just the user research behind it. There's so much to learn in order to do things right in the clinical environment, so I wanted to kind of see what works, what doesn't, what your experience is.
Cool. Good?
All good?
One last one?
Not far from here.
I just would like to know more about how service design helped you to came up with a proper solution for specific problems, and why we even want to replace human doctors with robot doctors and the technology.
Okay, cool. All right. Okay, cool. Let's get into it. So I have a kind of a strange career path in that I started at Memorial Sloan Kettering Cancer Center, which is one of the leading cancer centers in the world. I never thought that I would end up in healthcare. It wasn't where I thought I was going, and I never thought that I would stay there as long as I have. But once I was in it, I realized how many problems there are, and as a designer, any sort of challenges really become opportunities. But I probably should also introduce to you Watson, in case you've never heard of him. And we'll talk about it. It's not quite working yet. No? Have you guys seen it yet? Oh, come on. All right, I'll do it this way. So Watson is famous in the United States for winning Jeopardy, which is a quiz show. And how he won Jeopardy was they ingested answers and questions from previous years. So he learned from that information and then used that to beat two of the former champions of Jeopardy. That was in 2011. And there was, I think the story goes, an immediate response of this could work really well in healthcare, because similar to questions are a lot of unstructured data, so are health records. In fact, it's said that our medical health data will double every 5 years. And I read online somewhere it's going to be like 50 petabytes. I don't even know how much that is, but it's like 1 quadrillion in the next 5 years. So the clinicians that have to work with this amount of data on a daily basis are becoming overwhelmed. So, to answer your question, this definitely comes up in the work that I do as a design researcher. So I'm in the field, and I talk with users, and I hear this a lot from nurses or clinicians. In this one in particular, from one woman, I could see her obvious nervous reaction to when we were coming to talk to her about Watson. You know, computers are great, but people are better. And she was very nervous that we would be replacing her in any way. So I get this question a lot at parties too, which I've gotten here today. Will robots take our jobs? I get that question, and I also get people are very amused that Siri works for Watson. But I always tell people that that is definitely not our intention. Our intention is to help people do their jobs better and to be more available for their patients. Let's see if it's working now. Nope. Nope. All right. So I was watching a documentary the other day about Grant Out. He is a very famous chef in the United States. He has one of the top restaurants called Alinea. It's in Chicago. It's a very experiential experience. And so Grant, at 28, was on the top of his game. He had a #1 restaurant. He was in the press a lot. And he had a problem with his tongue. He noticed a white spot. And it kept getting worse, and he just worked through it, and he would put some gum on it. He would just power through. And his business partner one day noticed that he looked like a heroin addict. Like, he was totally emaciated. He had stopped eating, and he was like, dude, you got to get to a surgeon. So Grant went, had a biopsy, and found out that he had stage 4 cancer. So there's no stage after stage 4. And the clinician said to him, we're going to have to do a very invasive surgery, which will take the majority of your tongue and both sides of your jaw. So him and his business partner leave the office, and they go and get a pitcher of margaritas. And his business partner says, so what are you going to do? And he said, well, if this is my only option, I'm going to die. Because for him, a quality of life without being able to be a chef and have that as his identity was just not a life worth living. And you know, if you think about it, Grant is 28 years old. He has a young family. He has a prosperous business. And his only option for survival would really take away that identity. And so his business partner, worrying that this would get out into the press, writes a press release about his health. And the University of Chicago hears about it and frantically gets in touch with his business partner and says, bring him in, we want to see him again, we want to give him a second opinion. So they check his diagnosis, stage 4 cancer, but they said, look, we have a clinical trial. It's a radical clinical trial, and this might work for you. And he was like, sign me up. And I bring this story up for 2 reasons. One is to really highlight and talk about why one patient in one city would have 2 very different options that would mean very different decisions for him. And the second is to talk about the importance of clinical trials. Actually, the third is also, as a user research, is to tell this in a human story. A lot of times we can't actually take the people that we work with and share them with you, and since this isn't a public space and already a story that's out there, it's a lot easier for me to tell it with you. So if we're going to talk about the physician and why the first physician had only one opinion about the treatment options for Grant, I have a lot of empathy for this physician because of the amount of stress that these physicians have to go through. They are parsing through a ton of data. It is said that an individual's medical record is now as thick as a Harry Potter novel. On top of that, on average, they have about 15 minutes per patient to see. And it's just not reasonable in this amount of time and that amount of information to really get to the bottom of this patient's medical history, let alone start looking for new options for them. On top of that, new medical literature is being produced at amount that someone reading at 20 hours a day could not read it all. So not only does he have a ton of information about the patient, not a lot of time with the patient, he now has so much information about new treatment options, new trials, that he just doesn't have enough time to parse through. So, we talk about regulations and data. So this is another thing that makes things a little bit tricky in healthcare. In the States, we have HIPAA. So this is our regulations about being able to share patients' medical history. So while it's really good for us, it is very difficult for physicians to share medical history of patients. And it's to the degree of two markers. So if I have a very, very rare type of cancer and I have seen a doctor, those are 2 points that someone could identify me. So it's not even about name, age, it's like it gets to the level of diagnosis and location. So this makes it really difficult for institutions to even share information about the patients. But it's really good for us because the most intimate details of our life are in these medical records. So again, time is money, right? And as our cost of care increases, the time that a physician has with patients decreases. And so, as I said before, healthcare is slowly moving into this, sorry. 1 second, yep. So, as I said before, the amount of data is increasing at a rate that no human can consume. And then on top of that, having just a few moments with each patient and the rising cost of care, these physicians are under a lot of stress. So while it's easy for us to sort of think like, why didn't his first physician get it right? Why didn't he see that there was another option? The reality is he probably just didn't know what he didn't know. So the other side of this, no, we'll get there. Yay. So I also bring this up because Grant's story helps to illuminate the importance of clinical trials. A clinical trial can be a patient's golden ticket. It can be literally their last option. It's like in Grant's case. It's also the way that we find new treatment options and new cures for cancer treatments. So the more patients we can get on trials, the more we learn about different types of cancer, and then the more we can put that back into clinical practice. So finding the right patient for the right clinical trial is really important. Now, the problem with that is, again, you have a ton of data in the patient's medical record, which is as thick as a Harry Potter novel, and then you have incredibly detailed protocols for a clinical trial, which is, again, a ton of unstructured data. It's a ton of information that is actually written in scientific text, not in the way somebody would write a clinical note. And so in order to match the right patient to the right clinical trial, it's very tedious and time-consuming. So I want to talk about that in context of the product that I work on, which is Watson for clinical trial matching. Because Watson is really good at reading a ton of unstructured data, this is a perfect application for this space because, obviously, a ton of unstructured data on both sides and having to do this very tedious matching. So what I want to do is just share with you a little video of a team who helped pilot this. Let me see. We did this before. See there? No. Yeah, no, it does not. Remember we switched this and it was working. Ah, okay. We did it. Okay.
Our mission is the same as any community practice. To do the best we can with the resources we have and providing great care for our friends and family members in our community. There are several challenges for patient enrollment in clinical trials.
Our screening process typically takes between like 1 and 3 hours, depending on how many patients are there, how many physicians are there.
You have to open each chart as you go. You don't know ahead of time what this patient has.
If you have an integrated program with EMR, with fully digital data, it would be absolutely fabulous, both on the front end and the back end.
Once we actually had the first meeting where we saw Watson in action, we looked at reports of patients that Watson had immediately kicked out of the screening process because they weren't the right indication. That to me was huge.
Once I started to see what Watson could do with finding out the information from the patient's charts, from their records, pulling out lab results and mutation status and tumor status, it helps my job a ton by not having to go through and look at all that.
I first thought of how flawed our EMR was and how wonderfully Watson did in spite of that.
I think I actually got goosebumps when I saw the results of these first sessions with Watson. This will eliminate our daily screening. We can potentially go to maybe minutes having the screening once a week. It will enable us to get our patients on trial faster.
If you can enroll the patients faster and have more patients on the study can go faster.
Watson can screen not only for our local trials, but trials nationally. It can screen the entire cancer.gov database for trials at the same time.
In the long run, it can help the patient because then that's more drugs available on the market, that's more treatments that they have available to them.
Cool. So we talked a lot about the physician, but there is another player in the system who is the clinical trial coordinator, and this is the person that I work with the most to figure out their needs. And let me tell you, every single clinic works different, and every single clinical trial coordinator has adapted to their own way of working because it is so detailed and nuanced type of work. So even though I've worked in oncology for a while now, I still every day am learning new things as a researcher and understanding how they do their job. But there is a way that we do that at IBM. And so at IBM, we have someone called a sponsored user. So it takes a little bit of time to find this person, but they are our subject matter expert, and we actually bring them in to the design process. It takes a little time to match us with them and make sure it's a little bit like dating, but we bring them into the design process. We bring them into key moments of decision making and into playbacks with our stakeholders to make sure that they are our North Star and that our designs are always mapping to their needs. So this is just one way out of all the different ways that we do research, but it's definitely very effective to make sure that we're understanding the sort of very detailed nuances of their work. So our purpose and vision statement in Watson Health is giving hope and improving lives with the power of data and cognitive insights. And I think what I love about this is that in the work that I do, it's not only the patients and giving them an opportunity to be screened for a clinical trial, which they may or may not have been missed for, but it's also about giving hope and improving lives of the clinicians that are working in that field. Because it really is our objective to make their lives easier. give them back time to spend with their patients, to be more impactful, to be more involved, because that's what really matters. When you think about times of being in crisis, you want that personal human navigation. You don't want a robot. I think to answer someone's question about like 10 years, good, bad, I would say that for things like this, right, where you are, a patient is at their peak of crisis, they are never, ever, ever going to be satisfied with a robot, ever, because we want that human interpersonal navigation of crisis. And I think the dystopian future is creating any sort of tools that make their lives harder. Because right now, I think the average of every hospital has about 6 different systems that they use that aren't always connected to their electronic medical record. So just creating more places for them to go to try and find any information is a huge problem. So that's something we think about all the time. Like, this has got to be integrated with an EMR, or we're creating a barrier to use, because they are not going to use one more tool. Which is really interesting in the space that I work in, because it's ultimately they're not the buyers of these tools. The buyers of these tools are senior vice presidents of hospitals who think it's going to work really great. But ultimately, the people that use them, we want to make sure that it's working and not making them frustrated, and they're not going to use it. So let me get back to one of these. Yeah. As far as data privacy, I mean, definitely there's a huge trend in buying a ton of data, which I think is a really good thing. To see longitudinally how patients have performed on drugs is definitely just helps us all be better and improves our lives. I think there's always going to be a concern about that data being used in the wrong way, but so far I haven't seen too much that really gives me pause. It's more of in a really positive way to sort of see the real world evidence and be able to design tools that help people pull out insights from that real world evidence of drug trials. So that's all that I have for you today. I didn't really go too much into user research. I can definitely pull out a little bit more about how we do that. A lot of it is remote. It's definitely a struggle to get into any sort of clinic because PHI, personal health information, is around in these clinics, and for me as an outsider, I can't see them. It was a lot easier when I worked inside of a hospital to be able to see all that information. But yeah, there's some tricks to doing that. So one of the ways, especially to have a few tricks. So one trick that we use is, because we can't photograph normally in these clinics, even when I was working at Memorial Sloan Kettering, you can't take a photograph of a patient. And normally those photographs of people doing something, that's what you do in user research. You take photographs, you document things. It helps to tell the story better. So one of the things we do is just to recreate that scenario with other people that we work with, just to sort of show there are humans and they're using these things. That's one way. Another way is we have to just change everyone's name. I mean, people do that in user research a lot anyways, but definitely we have to scrub all of our data of any information of when we're working with patients or any health data. So yeah, thank you so much for joining me. I hope that answered everybody's questions, but if you have any other ones, I'm happy to jump in. Yeah.
I can do my running rounds.
Yeah. There's one.
Up. Yeah.
So, okay. Because I guess the effectiveness of Watson is only as strong as the data that he's working on. So how the data is actually how this the quality of the data is provided actually.
How is he ingesting the data?
No.
Or?
How do we know that the data that Watson is working on is actually valid?
Okay. Well, there's a number of reasons why it would be invalid. One of it is just human error. And one of it is sometimes the information's just not there. So 2016 was the last year that all medical records in the United States had to be digitized. So there's still a lot of information about patients that's in paper form. So they're still getting it all digitized. So sometimes, and this happens a lot, is he can't read data that's not there. So that will improve with time as people use these systems a lot more. And I think that's why health and tech is so hot right now, because we finally have data and digital information that we can use. But yeah, we do have people that train Watson to make sure when they're setting it up at any institution that he's reading the right information from the right medical record and matching it correctly.
Is there a way to go through that digitalized information and just to erase those which are actually not valid? Because I can guess that not each clinical information is up to date, for example, even if it's digitalized.
Oh, visualizing the information from the patient's record, or?
Whatever actually Watson has the access to should be digitalized, right? So then, is it? I don't think that it's always like a valid information. Is there like a way or process to check if it's if Watson actually should take into account that data?
As a visualization, the data that he's ingesting, or?
I was more thinking about, I don't know, is there like any specialists that actually go through that information and check if it's still up to date, if the treatment that was used in some clinical trial is still like, I don't know, still effective, or still, I don't know, that it's not using, I don't know, some medicals that are now not accessible, for example.
Oh, okay. So that the information needs to be like relevant information.
Yeah.
Yes. So he only reads the most recent clinical note unless you want to go further back. So it's not like information that's not, because if he was ingesting everything all at once, it would take forever. So normally when he's just scanning the patient, it's normally the most recent clinical note or any labs or biopsies. Yeah.
Okay, cool, thanks.
Yeah.
Thank you. So I actually have 3 questions, and I don't know if I'm allowed 3 questions. But, okay, cool.
We have time.
So the first one is sort of following up on that. How much cross-referencing are you allowed to do in between data, and like, it's interesting because like if you're a human and you're reading a lot of personal data, there might be some regulation, but is it the same for like if a computer is reading it, or like can the algorithm actually like cross-reference different medical records to find patterns and stuff like that?
There's definitely regulations. There's actually we just found this out recently. So a institution has to sign an agreement with a pharmaceutical company that they're gonna hold that drug trial at their site. And once they do that, they can then search for PHI in a patient's medical record to start matching. But before they sort of say like, we're gonna do this clinical trial, obviously like personal health information is need to know. So like once they're going to take on that clinical trial, then it is need to know, and they can scan for that patient data.
Okay. And the second question was around, so I'm not exactly sure how this works, and maybe this is like a stupid question, but obviously IBM it's not a academic institution, it's not a public institution, it's a private company. How does this collaboration work? Like, how does this collaboration work with basically like public healthcare and like I know there's pharma companies who also run clinical trials, but like I'm so clueless on how this works and like what the challenges are. If you could just elaborate on this.
Yeah, there's a lot of different challenges in that question. So we are only set up right now with private health facilities. So it's a little bit different in the States, but we have some that are clients and some that are partners. So the partners help us to train Watson, especially with Memorial Sloan Kettering. They did a lot of training Watson on a different product, but that same training is sort of the base of our product as well. But does that answer your question a little bit? No?
Not really.
Okay.
It's interesting. It's very interesting, but it was more like, from a European point of view, it feels to me like it's a little bit weird that like a company, like a business who wants to make money. But I guess it's true for pharma as well. That's why I'm saying maybe I'm just clueless. Like I was curious about whether it's how you protect basically the interests of the patients and like the general public. From like just IBM wanting to make money. And I'm not saying IBM is evil. I'm not. I think this is great. I'm just curious.
I don't think we've made any money off of it yet. So that's the, so it's definitely trying to help solve a problem. I don't think we've totally figured out how to monetize it yet. And I think that's definitely in a new business model. And what that business model is, I don't really know that well. As we kind of work as a three-legged stool, so there's design, development, and then we also have business. I'm sure that's true of a lot of people's companies, but the business guys are working really hard to figure out how we can monetize it, because we employ a lot of people to help train it, and not even like when we set it up, we have somebody in-house who used to be a clinical trial coordinator that helps to train people up on the other side, so yeah. So I don't know. Doesn't really answer your question.
No, that's fine. It's fine. So third question and last one, I promise, is around your personal background. So like, what brought you to like this is a very feels like a very specialized area. Like, did you have background in healthcare before, or like, what's your background?
Yeah. So why I was bringing up service design. Somebody asked about service design too, and I forgot to write it down. But so my background is actually in service and hospitality. And when I graduated from grad school, I interviewed at Memorial Sloan Kettering, and I was telling them how I actually was looking for jobs in service and hospitality. I was looking for innovation teams in hospitality. And they were like, but we want to do that here. We want to understand the patient's experience. And so there we did more of designing for physical spaces and services and how patients use different services within the hospital. And from there, just meeting with the patients and sort of starting to understand all the problems that there are in healthcare, I was just like, I want more, and I want to do like bigger things, because it is kind of like, at the moment, working in a house with a lot of leaky pipes, and sometimes we're trying to like build the house around the leaky pipes. But I do think that the reason why I was like banging on IBM's door was because they felt like they had enough muscle to sort of surround all those leaky pipes, and I think we're getting there, but it's early days, so yeah.
Any other questions? We still have time. Maybe a fourth question.
So I know that Apple have been talking a lot about how healthcare has enabled them to do kind of some trials as well, to be able to find people to do various kinds of trials. Is that something that you guys are interested in as well? Like how you could hook up Watson to maybe like healthcare data?
Yeah, so there has been some talk about that, and I think there has been a team that's tried to figure that out. I think that's an amazing use case for sure, because if you can empower people to get involved in clinical trials and in those more like micro interactions when they're just at home and can do it on their own time, that would be phenomenal, definitely. Yeah.
Just pass it down the row. So I've done some work with EHRs, and as you probably know, EHRs, electronic healthcare records, are a mess. There's no good ones. And so this is sort of piggybacking on the question back there about garbage in and garbage out and bad data. And there is, because the EHRs are so poor, a lot of poor data is going into them. So what, I don't know if this is a question or more of a talking point, but what can EHRs, what have you seen to say, like, how can we make sure that the data is good so that we have that nice feedback loop? I mean, other than just creating a better user experience so the data is better, are there any other ideas or anything you wish that kind of the EHR is the other side of the coin that can make that better and make Watson more powerful?
No, definitely. And I'm glad you brought that up because it was something I sort of skipped over. But EHRs are definitely built for billing and compliance. They're not built for user experience. And therefore, they're like really difficult to use. And no clinician likes using it. They're used to writing, they're trained in medical school to write in sort of like 5-sentence summaries. So a lot of them will use that dragon natural speaking to dictate it into the EHR, or they'll have somebody else do it, which then anytime you have somebody else do it, you're going to have some human error. I mean, you doing it, right, is one thing, but somebody else doing it is like another layer. But yeah, I think there's a huge opportunity. The problem is the sort of biggest player in the EHR game, they're very sort of closed and secretive about their work. So I don't know too much about their design process. They do say that they do UX design, but and so I have no idea, and these are my own opinions, but that I mean, I haven't spoken to a single clinician that likes using them. Yeah, and there's definitely a rise of startups that are trying to get into the EHR game. So I think the more can sort of shake the monopoly would be good. It's just the problem is healthcare institutions only make about a 2% profit, and that profit is generally just rolled back into patient care because their profits are so minimum. And so they're not going to spend a ton of money on like fancy digital tools. They buy the like bare necessities. Like, what do we need mandatory? Let's get that. And a lot of times, sometimes they're like buying pieces of a product and not like a full end-to-end experience. So I've seen that a ton of times where you go into a clinic and they're only using, like for example, I saw one call center where they were using the same software that the people in billing were supposed to use. It was a product for billing, but they were using it for scheduling, and it was just clogged up the whole system because it didn't work for them, and they had to like tab through like 3 pop-ups before they could actually get to putting the patient's details in. And meanwhile, you have like a patient that's really upset and in crisis and like talking your ear off and trying to like put all the information in really quickly. So yes, yeah, it's a problem. I don't know. I didn't really answer. I just sort of talked about all the problems.
I was wondering if you were going to bring up interoperability. So like just like the different EHR, like kind of having a standard on it.
Yep.
That's something that we really ran into. Like a patient would go see multiple doctors, and one doctor, just to get that, thank you. I like you holding the mic for me. To get that full picture is so important to see like not only what the oncologist is saying, but like what is the dermatologist saying? What is the what is the general health care person saying? Why were they referred in the first place? That's where like connecting those dots, where I would see that AI would have such a good opportunity to do something different that the one single doctor couldn't do. But right now, the systems don't talk to each other.
Yeah, that's a really good point. Yeah, they don't.
So like having some sort of like, I guess, basically a standard code to use for it would be really nice.
Yeah, and there's also like competing institutions, right? So like in the States, we don't have just like one healthcare system. We have multiple. So if you go to a different institution and then you're trying to transfer institutions, the institution can kind of hold back your medical records because obviously it's not their first priority to move your medical records over. They're already pushed to the max. So I don't think it's by any means intentional to withhold your information, but it's more of just not having the time or the resources to do it, right? So it's definitely a big deal.
I'm piggybacking on quite a few questions here already. I have an ethics-based question, and really more from, since you're a service designer, more thinking about putting a quality check and verification of what Watson is doing. Because I understand we are on the very beginning of that journey. That right now we're trying to figure out how we can aggregate all this data in one place. But very, very soon, the goal of such systems is to support decision making, if not making the decisions. And in that point, who's responsible if the decision is not made correctly? Because right now, yes, there's a lot of human error in a process, but in that world, it's very easy to kind of trace, compared to algorithms, very easy to trace that fault to a human. When systems like Watson come in place and decisions are made, especially in healthcare or automotive, where lives are in stake, what is being put in place, for example, in IBM, almost like a back-end service design to make sure that the system is ethically correct?
Yeah, so there's, and the product that I work on, which is Watson for clinical trials, there's a little bit less of that because he's doing sort of a first pass to weed out the wrong patients and give you a shortened list of the right patients. So from that, a clinical trial coordinator, instead of going through every single patient file, they have a shortened list, so they still have to work up the rest of the patients. But in Watson for oncology, I know that they are tackling this very problem because it's surfacing up treatment options for a patient. So if you're surfacing up a treatment option for a patient, and it's not just one, he's not saying like, oh, this is the treatment option, but like giving multiple of like, here are some, standard treatment options from different institutions. So I know that that is something that they're challenged with because that does bring in an ethical question of like, if he gets it wrong and they treat him, they treat the person in that way. But they have some clever workarounds of like being able to show where that, a physician is always going to look where that was derived from, where Watson was pulling that information and the backup of the research on it too. So I don't know too much about the legal ramifications of like, okay, let's say Watson treats a patient in the wrong way. But yeah, it's definitely not, it's something we should, somebody's thinking about it. It's just not me, unfortunately. Yeah. Oh yeah, sure, sorry.
Hi, thank you for your talk.
Yeah.
I was just wondering what happened to the chef you mentioned in the beginning.
The
Grant?
what? The what? Sorry.
What happened to him?
Yeah, I should tell you, right? Grant, he's doing well, he's thriving. Yeah, I totally forgot to tell you about Grant. He's doing good. So he got chemo and radiation, and he lost his taste buds for a while, but it came back. So he's doing good. Yeah. Mm. Yep, exactly. That's okay. No, I like it. No.
Okay, it's a little bit about follow-up for the previous question.
Yeah.
About making an errors. Humans are also making an errors, and if you are unlucky and your, member of your family dies, then you look for someone who is guilty. But it's a the medicine is an art. It's not like an equation that you can solve. So in my opinion, if Watson will be making less mistakes than beings, then it's pretty much okay for all of us, I guess, for society. Maybe it's not good for a person to know that a computer killed a member of a family. Mm-hmm. But I know the world is not perfect. There are some laws, and people will always fight for, I don't know, some, how to say it? Okay, it's to get some money from, let's say, company that make the program. But I think that if a computer would prove that a computer is better than an average human being, then it should be okay, I guess.
Yeah, he's definitely, because there's like different levels of AI, right? And he is not at sort of like the assistant level, he's more at the trusted colleague level. And I think maybe what you're talking about is more at like the boss level, where Watson's like, do this treatment recommendation. And it's, I think in oncology, obviously, like, these people have had a ton of medical training, so what we're offering is to allow them to look outside of their own understanding or their own institutional treatment recommendations and find other options very quickly, instead of having to go through a ton of medical journals or go to a tumor board meeting once a month and discuss the patient's case with another colleague, right? They can do it instantly. So, yeah, I don't think, it's less of him being like, do this, but more of like, here's some options for you, if that makes sense. A little bit? Okay.
To so many doctors, then maybe you can give, okay, it would be not like a human being, but it would be someone that you can go to the, I don't know, internet website and write, I have a fever, I can't sleep, and I can do something. And Watson will come up, you might look, maybe your illness is this and this.
Yeah, I think so. There's definitely the primary care example that you're talking about. There are people that are working on that, so I think that is future. Watson for Oncology is also live in India and China and Malaysia. I always forget. And so to your example, like they are treated with the same treatment options as somebody that lives in a very affluent, Upper East Side of Manhattan. You could live in and have the same treatment options. So it's out there. Yeah.
Okay, and last question.
Hi. I have a question about EHRs, and can you reveal which EHR have you integrated with?
Epic and Cerner, yeah. So two of the big ones.
Yeah. Okay.
Yeah, but a lot of these institutions have their own like sort of homegrown ones, which are much more difficult to integrate with. So, yeah.
All right, thank you.
Cool.
I'm worried about Dr. House now.